Welcome, everyone. My name is Zsolt Huszár, and I'm going to talk about risk factors of cognitive decline. I work as a psychiatrist at Semmelweis University. My supervisor is Gábor Csukli, and our vision is that in the future, cognitive decline will be avoidable by the widely used prevention programs. That's why our mission is to assist in the development of prevention programs. We have two specific goals. First, we would like to evaluate the association between pathological protein changes and the rate of cognitive decline by a meta-analysis. Second, we would like to estimate the role of modifiable dementia risk factors according to amyloid status. The title of our first project is a risk of conversion in neurocognitive disorders among beta amyloid and phosphorylated tau exposed subjects. And about the background. There are typical pathological protein changes for Alzheimer, which could start decades before cognitive symptoms. These are the senile plaques made by the accumulation of beta amyloid and the neurofibril tangles from the accumulation of phosphorylated tau. And it's known these proteins play a central role in development of Alzheimer, but it's still unclear to what extent the presence of these proteins accelerates cognitive decline. This is our question. So here you can see our PECO framework. We investigated two different populations. The healthy, the so-called cognitively unimpaired subjects. This is the generally used terminology for cognitively healthy people. And the other population, what we investigated, is patient with mild cognitive impairment. The exposure was obviously mentioned to different protein, and the comparator, the lack of this protein. And the outcome was a cognitive decline, which means the conversion to MCI or conversion to dementia. We made our systematic search on almost 15,000 articles. And here you can see our first results. The amyloid positive subjects conversion to dementia from MCI. The left side of the axis represents the beta amyloid positive subjects. You can see every results belong there. So we detected that the odds ratio for conversion, the overall odds ratio is 5.6 for higher in the beta amyloid positive group. While you can see the heterogeneity of the results was moderate, 48%. When not just the beta amyloid, but the phosphorylated tau was also measured, we detected that when both two proteins are pathological, the odds ratio for conversion increased to 11.5 for conversion in the amyloid and phosphorylated tau group. When only the amyloid but not the phosphorylated tau are pathological, the odds ratio is 2.8. And when there is no pathological amyloid changes, but the phosphorylated tau is pathological, there is no significant difference between the exposed and unexposed group and the odds in conversion rate. Sorry. And regarding the healthy, the cognitively unimpaired population, we detected very similar results. Here the odds for conversion in the amyloid positive group even higher is 6.8. About our limitation, the investigated population, there was a heterogeneity. Studies use different follow-up times and the strengths, that the large number of cases, and the measurement techniques, what I forget to mention, sorry. It could be measured, these protein changes, by PET-CTs or from the cerebrospinal fluid, or the measurement techniques are accepted in the field, the recommendation for that. So, the conclusion. Abnormal beta amyloid and phosphorylated tau levels greatly accelerates cognitive decline, both in the cognitively unimpaired and in the MCI population. That's why the most endangered population can be identified by detecting these proteins, and most endangered population can be identified before the appearance of cognitive symptoms. maybe the start of non-pharmacological or even pharmacological treatment should be related to amyloid and phospholipid status, not the cognitive status. And implication for researchers is that the efficacy of different dementia prevention approaches can be more accurately assessed by knowing these protein status. We submitted our manuscript to the Journal of Neurology, Neurosurgery, and Psychiatry. This is a third submission. And about our second project, the role of modifiable dementia risk factors according to amyloid status. This is a registry analysis. And about the background, 40% of dementia cases caused by probability modifiable risk factors. It's my most important slide. You can see the most important risk factors of dementia. So please encourage your patient to treat their hypertension, drink less alcohol, lose weight if they need, stop smoking, treat their depression, and do social and physical activities, so on. So it's known these are the most important risk factors, modifiable risk factors for dementia. What we don't know is whether the risk of these items is detectable once the pathological amyloid changes has started. This is our question, and this is our aim, to examine the significance of dementia risk factors in relation to beta amyloid status. We investigated these risk factors: depression, hypertension, obesity, hyperlipidemia, and regarding the last three, we handled them together. We calculated the so-called CAIDE score. CAIDE is a widely used, validated dementia risk estimation tool. We made this decision because these factors generally closely interrelated. And the data source was the Alzheimer Disease Neuroimaging Initiative, which is a multi-center cohort which provides access to its data. Yes. Here you can read our PECO. We investigated two different populations, patient with amyloid negative status and patient with amyloid positive status. Both, they are cognitively healthy population group. And the exposure of the already mentioned depression and the high CAIDE score and the comparative the lack of these risk factors. And the outcome was conversion to MCI or conversion to dementia. We expressed our outcomes in hazard ratio, and regarding the baseline, there was no association at baseline between the beta amyloid status and CAIDE or depression. This is the first results. You can see the dashed lines represent the amyloid negative groups, the continuous represent the amyloid positive groups, and the blue represent the risk factor positive groups. And here you can see the relationship between CAIDE and conversion. And in the amyloid negative group, we couldn't detect significance association when we compare the patient with high CAIDE score with low CAIDE score. But in the amyloid positive group, there is a significantly higher hazard for conversion in the high CAIDE group. Here you can see the relationship between depression and conversion. Here, both the amyloid negative and amyloid positive group, we detected significantly higher hazard for conversion in the group with history of depression. So the conclusion is quite simple, but I think quite also important. If pathological beta amyloid accumulation has already occurred, reducing the risk caused by CAIDE items and depression still has a significant impact on the risk of dementia. This is an overview. Here you can read my additional activities. And thank you very much for your attention.
Quite well said, that time too. Can we go to your, just for introduction, the question, can we go to the first conclusion of your studies? I'm just curious to, since
Sorry?
I mean, at this stage, I mean, the students are actually not expected to do kind of real translation of the meta-analysis outputs. I mean, because here that we at least after 1.5 years, I mean, they do their publications and then they do the conclusions. Still, I mean that. I mean, you conclude in the clinical implication that the most endangered population can be identified before the. So how would you do this, or how should this be done?
By measuring by PET-CT or from the.
No, in the real world. I mean, so do you have access to these people?
We have. So at the Semmelweis University, there's a possibility by lumbar puncture to measure the amyloid level.
Mm-hmm. Okay, good. Questions, please. First from the audience, not the audience, the active students.
Thank you. Amazing presentation. My only question is about the definition of MCI and unimpaired people and patients with dementia. Does this cutoff values are well defined and how do you measure them?
Mm-hmm. Yes, there are. Thank you very much for your question. There are the clinical and the simple definition is where there is a detectable decline by a neuropsychological test. That is the definition of MCI. And the statistical, there is the difference between the normal population and the MCI group is one standard deviation. But an MCI patient is able to manage their everyday life. But a patient with dementia is not able to manage their everyday life. This is the difference.
Thank you.
Thank you.
I have a question about great presentation. If someone has a family member, for example, who had dementia, if they want to make sure that how far they might be into this disease, and they go to this
to measure the amyloid
lumbar
status?
function or and if the result is coming back negative, it gives them how many years of relief and how often should this be maybe repeated? Mm-hmm. So if it's so earlier than the cognitive symptoms.
Thank you. The truth is, I don't know the absolutely accurate answer, but what is known that these protein changes can start decades before the cognitive symptoms. This was a question. Thank you.
Congratulations, Zsolt. My question is, what do you think? Is it worth to measure the beta amyloid level in a healthy population?
Thank you. It's difficult because it's helped a lot to identify the most endangered population and to give a better prognosis for those healthy patients. And also there is a therapeutical relevance because, as you show, to reduce those risk factors still important, and the treatment of dementia, the acetylcholinesterase inhibitors, has a significant but not high impact on reducing the amyloidosis. So it's an individual decision, because to know that I have a very high chance for dementia, if the odds ratio is 6.8, I assume is a very annoying information, but maybe this information can encourage the patient to handle their modifiable risk factors, for example. Thank you.
Thank you, Zsolt, for this great talk. I have a question in connection with the second study. So there is this phenomenon, the healthy user bias, when somebody is healthy, like coming from a good socio-economic environment with a great education, with healthy genetics or lucky genetics or something like that, and has less risk for depression, high blood pressure, etc. Then can it be a common source for this protective resource, or can you somehow count on this bias? So,
thank you for the question. It can be, but how the research worked on these risk factors, it showed that these factors had a intercausality, but these items are independently risk factors. But it's well known depression increase the risk of hypertension or social isolation or physical inactivities. Thank you.
In the second study, the neuroimaging was introduced because cardiovascular risk factors and diabetes and also then because of vascular dementia. So how much your results is to support that, and that's a connection between risk factors and Alzheimer, because you see compared to vascular related and worse.
Thank you.
In addition, the cognitive functions were measured, but we were imaging how much was it introduced in the study.
Neural imaging so the answer is only at the baseline was a neural imaging. I'm talking about dementia, which is not a disease but a symptoms, but the common point is the cognitive decline. And the hypothesis, there are research on how depression or vascular risk factors even could cause amyloidosis, but it's clinically at this point I think is more relevant that how these risk factors could cause any kind of dementia. So I have no information that regarding this research, how much percentage of the converted population had vascular dementia or Alzheimer type of dementia. I have information on that they baseline amyloid status and they had or haven't had dementia.
You mentioned in one of the limitations that follow-up time is a problem here. And please excuse my blissful ignorance again, but as far as I can imagine this, it's you either have plaques or don't, right? When you initially measure a patient. They either have the signal or they don't.
Yes.
And if they do, then as time progresses, they will eventually show some kind of symptoms, right?
Right.
So basically what you're measuring in the first forest plot is just the time variability, right?
Thank you very much. I understand you're right. That's
yeah, okay.
I mean, sorry, the last answer is no.
Okay.
It's quite important. Because we measure the odds ratio. So obviously, few of the studies had almost 10 years follow-up. The other part of the range was, however, 2 years. And obviously, after 10 years, much more patients converted to dementia. But we measured both the unexposed and exposed groups conversion, and we compared them. That's how we calculated the odds ratio. And we made a subgroup analysis when the median follow-up time was 4 years, and we compared the studies under and with follow-up time under 4 years and upper 4 years, and there was no significant difference between the subgroups.
Okay.
But this is a serious limitation. That's how we tried to handle it.
The other thing I didn't understand that's in your second study is the source of data. I know it's from a database, but I think the whole study hinges on how they collected the data, how you acquired the data, and then that will allow you to allow us to evaluate your results. So can you please elaborate on what's going on here?
Thank you. This is a widely used and high, according the field, is a high quality data source. And if someone apply, a researcher could get access its data. And we download their data with my supervisor. We extracted their data. There was information on the baseline cognitive status, the follow-up cognitive status, beta amyloid status, and so on.
Okay. The thing that kind of struck me is that it says global and multi-center.
Yes.
And I would assume that, I don't know, depression hits differently in the southern hemisphere and the northern hemisphere, or hypertension has a different effect in Asia than in South America. So did you somehow incorporate for geographical variation in the effect of the risk factor?
Thank you. Most of the centers are in the US.
Okay.
We have data on the race of the patient. That's true. We didn't handle or investigate it. There is an association. Maybe it's a limitation, and we should. Thank you very much for your comment.
So global means North American.
North American. Global is the so-called Western hemisphere.
Okay. And the last question is: you guys used some kind of Cox model, or
yes, Cox model hazard ratio.
Okay. So this is basically a multivariate Cox model that we see here.
Yes.
Okay. Thank you.
I joined the discussion as well. Basic things first, in terms, can we trust the data? What methods were used for assessment of MCI and dementia? Were they the same over the studies, or did they differ?
Thank you very much for your question. Yes, there is a so-called Peterson criteria, and it's not obvious, it's not the only criteria, but it's the most widely used, and luckily in the meta-analysis all of the study used the Peterson criteria for MCI.
And this is the gold standard for dementia, or is there a gold standard for dementia?
It's a gold standard for mild cognitive impairment, but for dementia, the diagnosis was made by clinical examination, both the function, the everyday life function, and cognitive tests.
Okay, so it's kind of soft definition. Good. Now, going back to amyloid and p-tau status, how can this be assessed? I don't know how. Maybe the question is stupid, but can this be done easily, or is there an invasive procedure behind it?
Thank you. It's quite expensive, but the cost is decreased by year. There are two measurement ways. The most expensive, but the less invasive, doing PET CT. There are PET CT both for amyloid or p-tau measurement, and also the most widely used is by lumbar puncture measurement.
So you cannot do the field study?
Just in a very few centers here at the Semmelweis University, by lumbar puncture we can do.
Okay, so population study is virtually impossible. Okay. Now, you had on one of the slides, you had disease-free survival. So I always love these disease-free survivals because it tells you nothing. It just tells you the chance you didn't see something. And this was then done that people were assessed regularly for the presence of mild cognitive impairment
Yes.
and or dementia.
Yes, thank you. Regarding the question before, in the ADNI process, there are assessments in every 6 months.
And done by same people who know the status.
Yes.
Okay, then. This CAIDE score, I checked what this CAIDE score is. Is that a very precise score? Is it a crude score?
It's an easy to use score, and it's. Sorry, maybe I don't understand.
Crude means that it doesn't tell you much. Because, it's BMI higher, lower 30, cholesterol 6.5
yes,
higher, lower, blood pressure 140 higher, lower.
Yes.
It doesn't take into account the therapy, for instance. So would you think that is a valid score, valuable score, or not so much?
Sorry, maybe I not understand absolutely your question. This score made by my exact threshold. So regarding BMI, after 20, upper than 25 is it has 2 score in the system. There are a range for regarding the hypertension, hyperlipidemia, and based on that, it's possible to get for a patient a better prediction.
Okay, but I believe it doesn't take into account the therapy. It just takes the measure of the variable. Maybe it's always better to have a linear a number in the system than to do the score. Yeah. Now the last 2 things, very short ones. Now, is it possible to conduct a definite prospective observational study to give the answer about the amyloid and p-tau status and occurrence of dementia, and how would you do it if you would be the one to do it?
Sorry, may I ask you can you repeat your question?
Okay, so this meta-analysis showed the results as it showed. Mm-hmm. So there is no definite answer what is the value of the.
Oh, sorry, you asked the.
So is it feasible to perform a study that could be a definite study to tell us, okay, if you have this status, then your risk is as it is, and how would you do it if you would need to do it?
Thank you. First, it's possible. We should we should find a predefined threshold, a predefined follow-up period, and outcome variance. But otherwise, these difference is so high. Maybe I do not recommend to do more study on this aspect of this research field, because it looks now also by a systematic search quite obvious that it has a significant and high impact on conversion.